Okay, recording has started. Hello, Walt. Hello, Rani. Thanks for joining me today.
Good day.
Hello.
You're coming from your university room in Norway, yeah?
Yeah, I'm at my office. Haven't been here in a long time, but it's next to where I live.
And Walt, you're coming to us from what looks like another dimension with the face coming out of the wall behind you. Yeah.
Get it. There it is, right there. Yep, I am. Yep, I'm about 4 minutes walk from my house too, so it's nice and close. So yeah.
Great. Thank you both for joining me today. We're going to be talking. We're just going to be having a chat, aren't we? Really. Complexity, causation, evidence-based medicine. Walt, that's what you wanted to talk about. And Rani, you're going to jump in as and when you're going to jump in and tell us all of the philosophy stuff. So let's begin. Let's start by saying, is there such thing as a simple interaction? Is there such thing as a simple patient or client in front of us? That's the question, Walt.
Oh, for me, sorry.
Yeah.
I seemingly so. If I can just venture off the voice domain for a minute, somebody comes in with a ligament tear, and to the clinician, that may seem like a very simple patient. It's cut and dry. You have an etiology. They had an injury. They tore the ligament, and you follow a protocol both mentally for healing, right, in terms of how long that ligament takes to heal, as well as an in-place rehabilitation sequence or protocol that you might work from. And I think clinicians view that as simplistic all the time. You might get that with somebody with quote unquote simple muscle tension dysphonia, but I don't think anything is simple. I think every interaction is complex or should be viewed as complex, both from the standpoint of the human being in front of us having a psychosocial past that may have led up to that muscle tension dysphonia, as well as the thing that goes overlooked, and it's the complexity of the clinician and what training and belief system we bring into the room, because I'm going to evaluate and treat that person with muscle tension dysphonia very differently, say, Stephen, than you will, or somebody who's been trained in a different interaction model, who's been taught to think it's different problems.
Yeah, and that's a big thing, isn't it? Because we're talking about practitioner bias a lot, and there's a I guess the bias is to the certification, isn't it? The stories that we're told. I mean, if we were to reduce it, is a chiro or an osteo or a physio manipulating the C-spine? Are they really doing anything mechanically different? I mean, you talk to them and they'll all be telling you a different narrative, won't they?
Yeah, very much so. That complexity of our training and our beliefs and the biases that we bring into the treatment room take what seems like a simple problem and makes it incredibly complex, and also adds layers of confusion to it, because the complexity of my training being different from your training and how I view your problem, it really enters into the domain, because if it doesn't match and align with the patient's going to be thrown off their center too. If they come into me, for instance, feeling that the cause was yelling too much, right? But yet we say, but the cause is muscle tension. Well, which is it? Causation, is it what brought it on in terms of the incident, or is it what we view as wrong with the patient, right? And there's just so many overlapping pages in this book that, we can try and simplify it, but to simplify it, I think, doesn't do it justice.
And so Rani, do you want to jump in there?
Well, I was just thinking that, is it the thing that you did, or is it something that is, that was already there before? It's similar in the philosophy of causation, because I think very often we are taught to think about the cause as something that triggers the effect, so it might be the last thing you add. So yeah, you were shouting or screaming a lot, but it could have been something that was there already, and the shouting and screaming wouldn't otherwise have brought on the problem. So another way of thinking of the complexity is to say that you bring in the background conditions into the causal story. So you say it's not only this, it's also these and these things, and I think that makes it, it makes it more complicated, but it also makes it maybe easier to feel that you can intervene or make a difference, because you might have one thing that is a problem, something that's damaged, and you cannot change that, but you can change maybe some of the other factors that might make it better or worse, So I just think this idea of thinking in as causation as something that is one thing, like we call it the monocausal model, it's just one cause, one effect, but actually there's a myriad of these causal factors that will influence the outcome. And I think, well, in one way it's a problem because it's complicated, but in another way it's also part of the solution,
So when somebody comes to me and I, in all my lack of knowledge, view them as a simple patient, and they've got mild muscle tension dysphonia, diagnosed by an ENT surgeon. They're a singer. They've had a pretty stressful run of some show or another. They're coming to me. We spend 4 weeks with some hands-on stuff, chatting about what's going on for them, and they secure the next job, the job of their lifetime. Their muscle tension goes away. I've done the same intervention for muscle tension dysphonia as I perhaps would have done with somebody else, yet I've had greater success. And to me, that seems like the simple patient, because I've been able to simply make a difference. I mean, that can't be the case, can it?
It can be. I mean, the two of you wove together and found a solution, or a diminishment of the person's problem. Obviously you alluded to the psychosocial factors of they've got their dream job. Now that they could have sent them off into an anxiety fit, and their muscle tension could have gotten worse, or it could have calmed all those fears because somebody thought they were good enough, right? And oh, my voice is good and I can do this and I don't have any fears of that, right? Those psychosocial factors are massive, but yet we all package it as oh, there, we did our thing and you're now singing better, right? And that's fine, because I think no matter whether you're doing manual therapy or exercise or behavioral based approaches, but sometimes the person gets relief in a very quick manner, which makes the person seem simple. But yet, why is it that the same person walks in the door tomorrow with a same set of circumstances, and the two of you can't seem to figure it out, can't seem to make that change, right? There's the complexity right there. Is it the complexity of the patient? Is it the complexity of you and your biases and how you've siloed things in terms of what's wrong with them? Boy, it's really, really difficult. And honestly, a lot of patients don't want to hear this complexity, right? And a lot of clinicians don't want to hear it either, because you've been trained, all we need to do is do this thing to your tissue or your pathology and you get better. A lot of clinicians don't want to hear that complexity of, well, maybe it's more than just the silo tissue that you think it is.
Sure.
But it seems like we're all part of this quite mechanistic worldview, where we think of things like, they're like machines. So, you have a car, it doesn't start, you look at the engine, you can disassemble it, you can find out which part that is, there's something wrong with this part, you replace it, you put it together again, this kind of view of the world has really influenced medicine and health sciences. And of course, when it works, it's really good. I'm not sure it makes the engine itself more simple just because it worked in the predictable way. I think it just means that the patient in front of you is more like the model you were taught to deal with, But I mean, it might be you fix one part of the car and it still doesn't start. It might just mean there's another part as well, but that would still be part of this view of complexity, that a thing is composed of parts that are replaceable, fixable and replaceable. And when you take it apart, you can put it together again. And I wouldn't call that complexity in a genuine sense. And I think that's also the problem with the biomedical model, that that it actually gives a bit of simplistic understanding of the complexity, that it's just a lot of different parts that there could be something wrong with, you know. But I'm not sure if it helps that we say, okay, you also need to add in something mental, you know, like the biopsychosocial model. I don't know if you use the biopsychosocial model in your field a lot, where.
Well, yes and no. I mean, the BPS is in and of itself reductionist, isn't it? It's like we started with kind of body mind dualism, and then we went, oh yeah, well, it's biopsychosocial now. And I guess it's just another way to reduce a patient to their components, isn't it? To their component parts.
Yeah, I mean, at least the idea is that these things can work separately, you know.
Yeah.
If it's not something physical, it must be something mental. So then you fix it, by going to the shrink, or, you know, you have to use completely different methods if it's something mental than if it's something physical, you know. And I think that's what Walt was saying also, you know, this idea with the silos, because you can be complex also within the biomedical model. You can have all these expertise, you know, areas of expertise that are still biomedical. But as long as we think there's something wrong with this part, you know, something wrong with the liver, or something wrong with the vocal cord, it's something wrong with the heart, you know, we're still treating the whole as something that comes in separable parts that work kind of like in isolation. And I think that isolation part has been really strong in the scientific approach to causation, because we have to take this one part and look at it in isolation from everything else and see what causal work it actually does, you know. So I think even genetics works like that. We take out the gene, we see what goes away, you know, and then we meddle with it and we replace it, you know. But
right.
if you have genuine complexity, then everything is going to affect, you know, everything is going to affect other things, and the whole is going to affect the part. So if the person is not well, the parts might be influenced, you know.
I would take issue, Stephen, with the biopsychosocial is reductionist as well. I mean, it can be. It's three instead of one. But I just, you know, a bit of my history. I come from a reductionist model where it's all about the fascia. Even though people say, oh no, it's the emotions and everything, there's still that narrow view of the biomechanical aspect of the connective tissue, which is viewed as dysfunctional. And I whether it's fascia or a muscle-based approach or even a nerve-based approach, to narrow it down to a simple tissue or system, I think is omitting that complexity of the psychosocial aspect. And I don't think that the biopsychosocial approach is another form of reductionism. I think it forces me as a clinician to realize that it's not just, like Ronnie said, it's not just an engine that I have to figure out which part is faulty and put that new part in or repair that part. While that can work, in fact, that's what most patients feel. They want to hear from me when they come in, that there's something wrong with the muscle itself, or there's something wrong with their posture, there's something wrong with the way they breathe. They want that simplified version. And while I'm not going to bore them with what we're doing here, not that this is boring, but most of our clients don't want to hear that. They want to know that we know what we're doing. They want a solution, and let's move forward. And I'm gonna drizzle this stuff in as we move along, that it's more complex, and that by introducing uncertainty, that it could be that muscle tension, but yet it could be a neurologic holding pattern from an event in the past, that sort of thing. To layer into them the complexity is a part of this, that it could be a simple solution, but no problem is simple, right?
Yeah, for sure. And I guess I'm just thinking now, you know, our biomedical model, I guess kind of, I don't know this for sure, maybe somebody else can jump in here, but that kind of, the Industrial Revolution brought us this idea of machines, and I guess, you know, a knee arthroscopy is such a, you can hold on to that as an idea. You go, because like scraping away tissue, and that seems very visceral. You know, I've peeled carrots. You know, I know how I can see that. That's very, you know, psychosocially, that's real to me.
Right.
But I guess, you know, when I watch you work, Walt, and you put your hands on somebody and stretch their skin,
And brain.
to get right. But that's, you know, that's what people are seeing, aren't they? They're seeing you holding their skin, and then they feel better, and that must be mind blowing for them, because they can get a knee arthroscopy. They get it because they've peeled carrots and they've scraped things, and they
Right. But no, okay, so few people come in asking for their skin to be stretched. Right? But yet, when I do my myofascial release, the old me, right, who was stretching their fascia, releasing their fascia, it was packaged as a story about something more complex, right? But the simplicity is, I'm stretching their skin. Okay. My patients still love leaving with a simplistic viewpoint. In fact, there's a really good study done where no matter how much we do with this education of psychosocial factors, the patient tends to leave with the simplistic mechanistic tissue-based story. That's still the one that they tend to hold on to, no matter how much me as a clinician tries to let them know that it's much more complex than that. And while that's disheartening, right, because I don't want that message being the take-home, it's a reality of I need to stop boring people and give them a little bit of the uncertainty and then move on with something that's helpful.
Mm.
Isn't it also, I mean, an expectation in all of us that, you know, if it's something physical, then someone else can deal with it, you know? If it's something with your setting, if it's stress, you know, it's your environment, if it's your personal history, it's kind of, you need to do a lot of things to contribute to the healing process. I mean, most people would like, I mean, when they go to the doctor, to get a simple diagnosis and a prescription and then, you know, go and get the pill. They don't want to quit smoking, drink less, start exercising, you know.
And the other confounding variable is it's, if you're not careful, speaking about the psychosocial factors can easily go back into hypochondriacal conditions, right? Where the patient is creating this. If I'm not careful as a clinician, when I introduce psychosocial factors, it could be, well, nobody can find out what's wrong with me, so therefore it must be in my head. I must be creating this, which has nothing to do with the psychosocial model at all. And that's a fine line that we as clinicians have to walk when we start talking about psychosocial factors. And you know, it takes some experience and some training and some tact in terms of how to introduce the multivariant type of approach that we're talking about here, instead of that really tempting simplistic tissue-based model or mechanistic model.
But it seems to me, Walt, that that your understanding of the biopsychosocial model is a bit more what we would call a holist approach, where you think of genuine complexity, you know, where things actually interact. Because one thing that has been a problem within the evidence-based framework with the biopsychosocial model is that you find all these risk factors, you know, and they are generated statistically. So then you find that, okay, having a certain age, being a certain gender, having a certain postcode, you know, they are risk factors that might cause, you know, but we know in reality, you know, it's much more complex than that. And if you start adding in, okay, so coming from a poor family, or, you know, then one would just look at one social factor, one biological factor, one psychological factor, and then add them together. And then it's like a more, you know, okay, so the car doesn't only have an engine, it also has software, and there might be something contextual blocking the, what do you call it, pipe thing in the back, you know. Exactly. So it doesn't start. So then you have a biopsychosocial model of the car, but it's still a car, you know. But it seems to me that's not the approach that you had, and I would like to stress that, because if we think that complex means just adding more stuff and looking at more factors, I don't think we get to the genuine complexity that you're working in, because and that's why some people in my cause health network, Lynn Getz and Anna-Louise Kirkengen, they work on how these biological mechanisms are actually quite complex. So even if you had the biomedical model, if you had a proper understanding of biology, you would see that it's a whole ecosystem, where actually you can get organ failures, you can get chronic autoimmune disorders from stress, from trauma, from from what happens to you in your life. And if you think of it like an ecological, like what we call an ecological turn, then we know that no organ is going to survive without the whole organism, and the organism is not going to survive without their environment. So if you make changes in the environment, that will affect the organism, that will affect the organ. So I mean, it's still something that a patient might find acceptable scientific explanation, but it's one that takes its inspiration from ecology instead of molecular biology. So it's a more top-down understanding of causation as well, which gives way to a more holistic approach to complexity. And I got the impression that you work much more within in this kind of genuine complexity view.
I believe that I do. I think what's interesting is I'm creating a coincidence that may not exist, but the coincidence of the three parts of a biopsychosocial model, if you could overlay the three parts of the evidence-based model onto that, but maybe somehow use those two together more than they typically are. They're often viewed as two unique parts of how we should be viewing patients, both from a biopsychosocial perspective, but we still need to use evidence-based practice. I think that's something that I keep thinking about. I don't know if there's been any research done about the coincidence between those three components, because I do think that, and I'm changing tact a little bit here, but that third aspect of the evidence-based model, patient values and perspectives, are the ones that really gets undervalued or underaddressed by a lot of clinicians, whether it's in the research or it's in the clinic. And if it's okay, I would love to sort of segue off there. I'm learning a lot about causation in terms of the philosophical aspect of causation from Ronnie, your a short introduction to causation. And that, because causation to me was always about what caused it in the body from either that tissue perspective or the injury perspective. But when we look at causation from that philosophical end of things, that's like, it's challenging for someone like me who never went into philosophy and looks at causation from those frameworks. All right. So go ahead, Stephen.
Well, no, I was just, obviously the people who are going to be listening to this are vocal coaches, singing teachers, speech therapists, those working with voice, massage therapists. And I'm keen to just outline the evidence-based model, Walt, if you wouldn't mind talking us through that. I'm not sure that it would be implicit knowledge that many of the kind of viewers of this might have. The other thing is that how then, I mean, there's a lot of evidence out there, and maybe this is a question for Rani. It's that, how do we apply that to a complex person? So, well, let's start with let's start with what the model is first.
Evidence-based model is basically three. It's often diagrammed with three circles, somewhat overlapping, or a triangle, with the research, the published evidence as one of those components, with clinicians' experience applying the best evidence. And the third part of that model is patient perspectives and values. Now, I've been listening to a lot of podcasts, doing a lot of reading on that first one. First of all, the research, which seems like it should be cut and dried, but you can find research, even quality research, that comes at a problem from drastically different perspectives. Okay, I'm gonna go back to my physio profession for a moment. Okay, a person is having pain, And someone could come at it from that exercise-based perspective to say, look at all the good evidence for exercise. And people go off on tangents of, well, the person's too weak, so we need to strengthen them, et cetera. But exercise has a pretty robust evidence base for pain. But then you look at manual therapy. Manual therapy can be seen as a viable intervention, and there's a decent amount of evidence for manual therapy for pain. So which one do you use? They're both considered good, although there's a lot of people in the PT profession who feel that the manual therapy evidence is crap, but I'm not going to get into that, right? Because you have published evidence for both of them. So that's where my bias comes in. It's often seen like, well, I'm gonna look toward the evidence that supports my bias, even though we're not supposed to treat like that, right? You're not supposed to already figure out what your intervention method is before somebody walks in the door, or you're not truly using informed practice, okay? But it's me applying that evidence. But I think that the thing that goes underserved is the patient values and perspectives. Now, if I'm a clinician who uses manual therapy and I have a website which shows me doing manual therapy on my website, the patient pre-selects me, right? They've seen my picture doing what they think should be done for their problem. And they didn't go to the exercise-based physical therapist down the street because he's doing that exercise without touching them, right? So I think the manifestation of the patient has already self-selected me, and they've self-selected the evidence based on their own experience. Okay. And I'll go off on my tangent of why I think that patient values and perspectives are way under stress by clinicians in a moment. But does anybody want to kick anything there?
I mean, Rani, do you want to jump in?
You can go ahead if you felt you were on a roll, but
yeah, well,
if not, I mean, if you're
I don't want to hog the conversation, but I love hogging the conversation.
I was just thinking, when you say patient values, patient preferences, I mean, I would have liked to see that that final part also including patient evidence, because I mean, the evidence that comes from research, it's evidence about everyone else. Mm-hmm. I mean, it's not evidence from your patient. And it's a bit like, okay, even if you're going to fix a car, if this is your approach, that it's a car that needs to be fixed, don't you need to know, like, if this is a Citroën or a Volvo before you start doing so? I mean, there must be something that is a bit specific to this type of car. Mm-hmm. And I'm just thinking, shouldn't we say that if you really want to be evidence-based, then the evidence of what the patient, what is the patient context, that's really important? Because if you think of complexity from a causal point of view, then it would mean that it's not only what you do to the patient that is interesting, right. It's what's meeting that intervention. So one intervention might work in one context and another intervention will work better in another context. And if you do the same intervention to everyone just because they have a particular diagnosis and a gender and an age, you might actually end up hurting someone.
Yeah.
And so what I remember you sent me a video that you made where you showed how you work with patients, and it seemed to me like you were actually collecting patient evidence as you went, because you kept asking, like, okay, so is this uncomfortable? Do you feel where, So, right. And another type of patient evidence would be to know something of their medical history or something about their context that could be causally relevant to their situation. Because I'm also guessing that it matters what is the causal story for their symptoms. I mean, so you could have the same symptoms, but with two different problems underlying. And if you have two different underlying problems in two different patients, maybe you should also address that underlying issue. Right. So that's how I'm thinking of these three talks, that it shouldn't just be about their values. It's actually stuff that it's information that could harm them.
Right.
And
there's where I think there's a big disconnect with how I see a lot of clinicians working, whether it's in the manual therapy for voice or the broader context of the whole body, is there's an acknowledgement that psychosocial factors can influence the problem. Okay. A lot of clinicians and educators look at that, the person's past and what brought them into your room, that, okay, they've got muscle tension dysphonia and they may have anxiety disorder, or there might be some underlying other social issues. But it seems like that the broadness of looking at the larger piece of it ends when they begin the interaction, when they begin the treatment, and it becomes more of, okay, you came into me, I understand your past, but here's what's wrong with you, and here's what I'm going to do to you. Now, they don't voice it like that, but in a way, they sort of tune the patient out. Or if patient perspectives come in, it's just a simple, how's the pressure question, right? How's the pressure? And if the patient said it's fine, I think too many clinicians feel like they checked in with the patient, so they tick that bottom box of patient values and perspective. And then they move on with what they think is wrong and what they think needs to be done to make it right, okay? And I see this in voice, in terms of manual therapy, and I see it in the broader context of the whole body. Instead of turning off patient perspectives and values as soon as we figure out what we want to do, why don't we include the patient in that? And whether it's manual therapy or exercise or other sorts of things, it's like asking the question, how does this feel to you? Does it feel relevant? Does it feel familiar? Is there anything about it that feels like it might be harmful? Is there anything about this that feels like it might be helpful? Those are my favorite questions to include the patient into the model. A lot of them don't like playing my game. They don't want to work so hard because they expect me to know what's wrong with them, and they expect me to know what to do. And in fact, they'll tell me that. It's like, well, I know a lot, but I don't know what you're feeling. I don't know what you're fearing, and I don't know what you feel might be helpful until I include you in this. And I guess what's become my goal in life is to get people more on board with including the patient more throughout the process and not stop when we start evaluation and treatment. I'll say it one more time. I think the patient perspectives and values are basically glossed over. And even when I read the evidence, when I read the research, and I listen to really well-regarded clinicians, there's this minimal attention paid to that third part of the biopsychosocial model, which I think is shameful.
That's interesting because, in the coaching environment, when you're put through your paces as a coach, the first thing that you really start to understand is that although you might be able to guide somebody to an acoustic change, that actually, if it doesn't feel great for them, it's probably the wrong change. And this idea of if it feels like tension, it probably is for them based on their experience. And particularly, if we're working with singers who really understand their voices, who through something have their voices have gone wrong, there's been dysfunction, there's illness, whatever, then when they come to us, the question, the feedback, that patient-centered feedback model really is the thing we're talking about here, isn't it? It's that getting it, but interestingly, I see it as coaching. I see it as and so that's what when I first came across your work, Walt, would it be 3 years ago now, 3-ish years ago, and when we had that, it's funny, I was talking to Rani and saying, I was kind of doing something in London and I didn't know Walt existed in New York. And then when I found he existed in New York, I had hair then, I went, I'm not going crazy. There's somebody else out there doing this. But I had reached those conclusions not through a manual therapy, evidence-based, the patient-centered stuff. I'd come at it from a coaching perspective and going, well, it just seems useful to ask them whether it feels useful.
The problem is the higher up you get on the experience and credibility in terms of your peers and your patients, the more you are expected to have the answers for them because you're the expert, right? And when a patient comes to us seeking expert advice, it's a balance that we have to sort of negotiate, letting them know that, I do know what I'm doing and I've been doing this for a long time and I think I can help you, but then handing some of that responsibility over, or not handing it, but requiring the responsibility
letting them into their own.
And you know what? It's not easy with a lot of patients because they're expecting me, with somebody with this many years experience, to know what to do. Why are you asking me if this feels like it could be helpful, right? And again, that's just that's what I love about my work. It's not a simple mechanistic type of a let's fix your muffler now, right? Let's see what might feel helpful, and if not, we'll recalibrate and we'll try different things. Whether it's my favorite, which is manual therapy, or exercise, or movement, or other sorts of interventions, which kind of brings in that coaching aspect too. I just think, you know, Ronnie, I first came in touch with you when you did Oliver Thompson's podcast with him, and I saw that part of where you had said something about the, you know, in terms of patient values and perspectives. It's like, it's not, we could give them a choice between a pill or an exercise, and I don't mean to diminish what you said, but in a lot of ways, that's how a lot of physios and other health professionals view the biopsychosocial model, or I'm sorry, the evidence-based model, in terms of patient perspectives and values. It's like, okay, let's give them a little bit of input, but then ultimately, I am the expert. And I think that we really need to honor that those are three equal circles, right? That the patient values and perspectives really gets so undervalued. And going back to George Engel's model, when he created that evidence-based model, or wait, did he create the
Biopsychosocial?
Sorry, I get those three circles that confuse me. What was the original intention of the evidence-based model when that was introduced as an equal part of this equation? Okay, I just think it's gone by the wayside, and it's almost been forgotten because experience and knowledge, and it just takes so much precedence over the values of the patient.
Interesting.
But what do you two think about the importance of having proper time before deciding on an intervention with your patients? Because I hear from clinicians that this is one of their biggest problems, is that they're not given time. They have to generate a diagnosis and make decisions on treatment from very little information. And it's always a pressure. So it's about time, it's about resources, and it's a lot of pressure on clinicians to do things very quickly and save costs. So I mean, that's why I'm really interested in this patient value, patient preferences part, and the whole part of the patient evidence. Because if you have 10 minutes, if you have 20 minutes, there's not much you can do. But you can prescribe a pill. You can do something quick and easy,
Yeah, I don't mean to be glib about this, but I think that's an excuse that a clinician might use. I don't have time for that. I think that's a lame excuse for that clinician to say that. And yeah, they might only have 10 minutes, whether it's a physician in terms of the time they have, or in a therapy model, some physical therapists only have 10 minutes because they've got to see X number of patients an hour. But I think that the way we prioritize information is so biased away from the patient that it's like, I don't have time for that, because if I let them talk, they might chew up the whole session. But therapeutically, that might be exactly what that patient needs. And even as me, a physical therapist, or working with voice or whatever, that allowing them their story, their input, that could be so therapeutic in and of itself that my intervention is less important that day. I do think it's a lame excuse when people says, I don't have time for that.
Moving on from that, there's something interesting about spending half an hour or maybe 45 minutes just doing a really nice detailed case history, and we're just talking through, and and then, and I mean, we're talking about causation today, and kind of correlations and stuff. But when you get the person who had a blunt, they were kicked in the larynx by a horse, and that coincided when their muscle tension dysphonia started to happen, and then they go, oh, do you think that would that have mattered? And to me, sitting in my big fancy chair, I might think, well, of course it might have mattered, but they go, well, I didn't make the link. And so then I might then do a hands-on intervention or a coaching intervention and probably they'll come away and go, that exercise, that was the one, that was it. And they'll come back and they'll say, hey, next time, can you do that again? Because that really helped. And I'm going, I'm not so sure it was what I did with my hands. And I think that's you know, kind of where we're headed with this, isn't it? Is that there's a that part of the patient's experience.
Right. And whether we use our hands, whether we're standing across the room and having them do an exercise or a training, it's simplified to say, yeah, that's all we're doing here is we're giving you more freedom here. But there's so many things of in terms of valuing and acknowledging, in terms of the way I view this, if I can do something where the patient says, ooh, that's that feeling I get when I get vocal strain at the end of a performance, I'm not only doing something to the tissue, but psychosocially, I'm impacting with their experience, the negative experience, possibly the psychosocial factors of that experience, how it might limit their performance, how it might limit their career. And we've simply done a simple touch-based experience that connected them on all three quadrants of potentially biopsychosocial. And I think that inclusion approach is so much, I think it's so much more important than, okay, patient, shut up. I found out what's wrong with you. Let me fix this, which they don't say it like that, but really that's what a lot of muscle tension dysphonia work is. We need to lower your larynx, right? So they go in and they manipulate the muscle or whatever, or they palpate that muscle and they say, here is the problem. This muscle, this muffler on the car, it's not working properly. So let's go in and manipulate it. There, you could talk better. See, it was your muscle. And patients love that because they want it simplified, but it is so much more complex than that.
So I guess, I mean, Rani, do you want to come in on that?
No, I'm good.
No, you know, I guess what can we do to change the world of vocal rehab here? Because, you know, we're in a position where vocal health education, we've got some of the world's leading experts teaching our teachers. That's why you two are here. You know, so I'm kind of going, this is conceptually, this is fantastic. And it's great that we kind of start to dip our toe in the ever, you know, kind of complex, muddy waters of causation. But how do we make this so that we can use it? Because it isn't simple. And that's the challenge, isn't it?
One thing that I would say is a practical implication of complexity is that, you know, if the world is complex, if a process is complex, then it means that different types of experts will notice different things, you know, that are equally true, you know, so they're equally relevant. So it means that from your perspective, from someone else's perspective, you know, they might pick out different things. So I really think having more interdisciplinary teams working with someone is definitely something that's going to help. And the way it is now, it's like you go to different specialists, and those specialists, they don't necessarily get the chance to talk to each other. I mean, because of time restrictions and just organizationally, you know, divisions that are maybe very artificial compared to the complex whole that you're actually seeing. So I think if you can have a team, like what is very often the case in rehabilitation teams, you know, they need to be interdisciplinary. But you also can't have a standardized procedure where you say, okay, everyone should go through this, and this independently of who they are, and after 3 months, that's it. You know, then you should be cured. I mean, that's not how it works. You need to have different perspectives on the same issue, and you need to have adaptive treatment. You need to adapt the treatment to that individual and their unique setting. So I would say if you have a real understanding of complexity, then you would start from the assumption that if everyone is different, they might respond differently to the same kind of intervention. You know, so I need to find exactly what they need at this stage in the process.
And just, you know, something that we were chatting about separately, Rani, about how sometimes particularly when people are going through a rehabilitation process, it's too early on for them. That they might have surgery, they're post-surgery, and that they're then shoved into this prescriptive fix in 6 weeks, and you'll get this half an hour, bish bash bosh, off you go, all better. And they go, well, I've only just got my head around the fact that I had surgery.
Yeah, or that you lost a function that was really, really important to you, so you might be in some sort of crisis in your life. So yeah, I was talking to this rehabilitation team at the hospital in north of Norway, and they said they felt the pressure to start immediately with rehabilitation, but they said actually, when the 6 months have passed, maybe that's how long it's going to take this person to feel, now I'm ready to start rehabilitate, to start doing the exercises, start making the changes in my life, because before that they were in crisis.
But then you get regression to the mean too. After 6 months, there's going to be, in many cases, a normal return to function, right? But yet, when we're talking about the vocal rehab, et cetera, they're coming to you because they've got a problem now and they want it dealt with now, right? The team approach is, I think it's crucial, but the team approach, in a hospital, it's easier to have that team, although it's tough to get people to work together sometimes. But when you're working like you and I do, Stephen, or you've got more of a team approach than I do, it's just me here. I certainly will. I like to refer out, but I have to be honest that I'm viewing this patient from my bias. I don't address breathing in a way that a breath specialist might. I don't address posture in a way that a singing postural approach person might, but knowing that those are all, they could be relevant factors. I just need to keep my referral list open and ready to say, okay, maybe you should see this person instead of me, or in addition to me. Those are ways around that. Because I'm as biased as anybody else. I'm as biased toward, I want to include the patient as much, and sometimes that isn't the best approach. Some patients, they want to be told what to do, or it seems to work well. Or some clinicians can't work from my rather fuzzy logic model, where we're going to start a relationship here before we actually start treating. It's that we're getting back into complexity, because trying to make this apply and applicable, there's no one-stop shopping to figure out how to do it best.
And I think as well, I mean, at the Voice Care Centre, we've got a nutritionist, a mindset coach, osteopath, 2 speech therapists, vocal rehab coach, and then 2 massage therapists. And when you start to look at that as the multidisciplinary team, quite often I'm going, do you know what? We've done it. We've got the team. We can help anybody. And then there'll be one person who comes along, and I'll see them, and the nutritionist will see them, and the surgeon will see them, and we can't make headway. I mean, are they more complex than the complex ones? And will we ever know? Rani, do you want to jump in on that? She's like, no, I do not.
I'm not sure what you meant. So do you say that you can't agree on how to approach, or?
Yeah, what if there's somebody who, for example, comes to myself and my team of 8 specialists, top people in the field, and they have what we would consider a simple diagnosis, simple muscle tension dysphonia, kind of non-specific onset, and they see every single one of us, maybe many times, and we can't make headway into their condition. We can't help them. I mean, and we're all fairly biopsychosocial at the Voice Care Centre. Are they more complex? Is there something that needs to happen to them that a multidisciplinary team can't provide?
So I was starting this cause health project from these medically unexplained conditions, where I learned from clinicians that 30 to 50% of everyone seeking care don't get help, just because the common interventions don't work, and you might think that those people are really, really complex. And a lot of the general practitioners in my network, they say, yeah, I mean, they have seen so many specialists. Some people, they have gone through their whole life seeing lots and lots of specialists. They have had surgery, they have had all sorts of things, and no one has helped them. They have maybe been on a lot of medications, they got a lot of side effects, and they have medications and surgery to deal with the side effects. And Anna Louise Kirkengen, she has a very interesting background where she has ended up treating, because she was the only female doctor, general practitioner in her area, so she got a lot of women, and a lot of stories emerged to her about sexual and physical abuse that would explain a lot of their problems, but if you treat them only from their symptoms, they don't make sense. So for instance, there was this patient who had been in the hospital maybe 7 or 8 times, and they have had surgery and removed various parts of their body, and every time, because they were in severe pain, and every time something was removed, it turned out it was nothing wrong with it, and there was this young doctor, and she had heard a lecture by Anna Louise Kirkengen about childhood abuse and childhood trauma as a cause of adult complex illness, and she said she suddenly remembered that, and she said to the patient that, I have time to talk if you want to talk, and the patient actually told her the story of abuse, and that was the first time that patient left the hospital without being cut. And I just think, it seems like this is a more complex person than everyone else, but it seems more complex because there's something unknown that the normal tools, the normal approaches cannot target, but it didn't take very long to find out. And Kai Brynjar Hagen, he writes a chapter in our book, and he works on people with morbid obesity who are going in for surgery. And there is a problem with people getting bariatric surgery, that it's a risk of suicide post-surgery. And he takes the time. So he takes the time to talk to them for 2 hours interview. And one of the things he asks is how their childhood was, if they were happy in school, and if they felt safe at home. And just if you felt safe at home and if you were happy in school, that usually triggers a lot of stories, that no one has asked before, because all they care about is your hypertension and your weight, and that you should exercise, and that you should, and he says the problem is that these people are treated only according to, the effect of their problems, and they're never being treated according to the underlying cause, which is the same type of underlying cause that you might have for kind of substance abuse, or anorexia, any kind of eating disorder, but they're not treated in the mental care system because there's nothing mentally wrong with them. They're not acute psychotic, for instance. So I think that's why I was saying this kind of patient evidence, it doesn't have to be very fancy evidence. It's just about knowing more about this patient, like what happened to you, what has happened to you that may have led or contributed to this.
Yeah.
And yeah.
And then you overlap with their concept of causation, maybe, right? Because they're going to have that. But I think sometimes just allowing yourself the time and the space to say, tell me your story, right? And see where that story goes. And it goes back to, Ronnie, what you said. A lot of clinicians feel like they don't have that time. I don't quite know how to address that, because I just would say, well, then find a way to take the time. Okay, find a way to prioritize allowing the patient to tell their story instead of cutting them off to get to what's the good stuff or what's necessary because you got to move on. You may be missing that opportunity to really help that individual.
So what Kai Brynjar said is that a lot of these people, they had never been asked anything. And when he talks to his colleagues, they say, oh yeah, I did understand that there was something underlying, something. But I'm not a psychiatrist. I'm not a psychologist. I don't want to. I mean, I might traumatize them, if I start talking. And he said he has never traumatized anyone. He actually experienced that they feel a relief that someone cares about those things because no one has focused on their life story before, or why they overeat, and so I think this worry that you open up a can of worms and you don't know how to deal with it. If you do, it's easier to just focus on the thing just in front of you,
Yeah. I think what you're saying is the simple, I say it more simply, that it's just giving them time to tell their story, asking questions, motivational interviewing, shared decision making, instead of it being a one-sided, here's what I think is wrong with you, here's what we need to do. Give it that time to develop that relationship. And Stephen, you talked about with a patient who comes or somebody comes to see you at your multidisciplinary clinic, and you often help them, but sometimes you don't, and then they go next door or down the street and they go to somebody else who helps them right away, or somebody who's an absolute newcomer to the field and they hit it out of the park. Is that because all of your staff is ill-equipped, they're ill-trained? No, there's the complexity of that relationship that other person, they talked to them in a certain way, or they ticked a box, or something opened up, and the relationship was part of why they got better instead of the skill level that they had. And I as an experienced clinician, you get used to not being able to help everybody. Nobody can, right? And one would think that the more experience would equate to you'd be able to have a better chance of helping somebody. But I think that's our ego talking, right? I'm fully aware that I may not be able to help you at all. Or even if I help you, I may never truly know what was wrong or what the cause, right? And which seems completely out of place, that if I help somebody, I must know what's wrong with them. No, not necessarily. Maybe we just developed a relationship that was helping in that way, like Ronnie, like you said.
I think that's a very profound place to lasso up our conversation of complexity. It's always an honor talking to both of you individually, but to get you into a room has been fantastic. So thank you, Walt. I know it's early for you there, and Rani, thank you for taking the time out of the day to come and chat with me here today. So thank you very much, and all of Rani and Walt's bios and their CVs are going to be below, so you can read up about them. One thing I would like to end with is the Cause Health book, which is free on the Springer website. We'll link it. It's a fantastic read. It's for clinicians, but I think a lot of the work overlaps for singing teachers and vocal coaches. So thanks very much. Thank you, you two.
Thank you.
Thank you for having us.
Right.